Great marketing ideas don't just fall from the sky. Innovative brands aren't built by...
We'll guide you through how to put sticky notes on your Windows desktop. If you find this useful, then please consider subscribing and liking the video. Search and go and type worry, search for mic, and here it is. And then what you... So you can click on it and you can go and install it. And then what you on it. And you can then go and place it somewhere on your desktop.
Unfortunately, sticky notes doesn't give any options to keep it on top of other opened applications on Windows. If you don't want to install a third-party sticky notes, then you could instead use on Start, search OneNote, and then click here to open OneNote. Then you need to go to the View tab, and here you can see an option called New Quick Notes. Click on it, then the quick note would open. OneNote, click on Start, search use OneNote to notes. Then you could a third to do is to first open pinned quick note applications. It would still be on the top. Now you could even close OneNote quick note to be open.
I never really set out to be a successful artist. For me, it was really just about self-expression.
Hi everyone, Kevin here. Let's go ahead and click on that. This opens up the mouse settings dialog, and within this dialog, let's go over each one of these files here. This is one of these different options. So you have as a halo around it. So where do we find a cursor file with a halo around it? Well, there are lots of websites online that let you download cursor files. Before I pull together this top tab here, is when I have normal select highlighted, this is my standard mouse cursor, I'm going to go to browse, and within browse now I want to browse to the new file that I just added. Control over, first off, how big the halo is. So let's say I wanted to make a really big halo. I could adjust the width and the height. Here I have a perfect circle, but you could also make it more of an oval. But there I have a
In this video, I'm going to show you how to highlight your mouse from the screen. Click on the Gallery tab. Now in the search area, type Highlight Cursor. From here, we're going to click on the Order by Downloads. Now you're going to see different options for you to
Hello friend, yellow line, and when I click it just goes like this, red when I left click on it, and when I let's go.com, and you just have to download this. I have already downloaded it. So now what you have to do is, so it will be a zip file like this, and you just have to extract it, and once extracted you will see something. Now what you have to do is, so it, and if you click on F color you can change to red. You can go to settings, and if you click on F8 again it will come again. Basically if you click on this it will go away, it will, if you click on this again it will come by. You can play with the opacity as well if you would like to do so. You can key does, so it will show in green now instead of red, and you can change this show click animation text. So if you click, if I enable it, when I click like this it will show me left button click or right button click or control C. I am doing controls, anything which I am doing right now. So it will show each and everything which I am doing on the screen right now. I don't want it, so I will disable it as of now. But that's it. So you can download this and enjoy and get those cursor pointers on the screen when you click.
Multiple sclerosis is a disease that impacts the brain and spinal cord, which make up the central nervous system that controls everything we do, whether it's taking a physical step or solving a complex problem. The exact cause of MS is unknown, but we do know that something triggers the immune system to attack the brain and spinal cord. The resulting damage to myelin that insulates wire-like nerve fibers is a disruption of signals to and from the brain. This interruption of communication signals causes unpredictable symptoms such as numbness, tingling, mood changes, memory problems, pain, fatigue, blindness, or paralysis. Everyone's experience with MS is different, and these losses may be temporary or long-lasting. Most people initially have relapsing remitting MS, where they experience attacks of new symptoms followed by periods of time when those symptoms go away partially or completely. Others experience gradual and ongoing loss of function without distinct attacks, which is known as progressive MS. MS can be difficult to diagnose, but once a diagnosis is confirmed by a neurologist who is knowledgeable about MS, there are disease-modifying therapies for reducing attacks and slowing down the damage. Growing evidence suggests that early and ongoing treatment with a disease-modifying therapy is an important defense against future attacks. There are also treatment strategies to address some MS symptoms. Options are still limited for slowing down or stopping progressive MS. Worldwide research is accelerating the discovery of how to slow down or even stop progressive MS, how to repair nervous system damage and restore function, wellness strategies such as exercise and diet that can help people with MS to live their best lives, and the exact cause of MS so that it may be prevented for future generations. To learn more about multiple sclerosis, connect with others to drive research for a cure, and to address the challenges of everyone affected by MS, visit nationalmssociety.org or call 1-800-344-4867.
It got to a point where it made it difficult for me to, you know, go to events or be anywhere where there wasn't a restroom around.
You're kind of embarrassed to even talk about it with your doctor.
My first hurdle was just to accept, the embarrassment and notice that I had to go seek treatment. That's when things started turning around for me. It affected everything. Now I have MS, and now I have my bladder issue, and now I have my bowel movement issue that I cannot control. It really it was sad. It was really sad.
When I was at home, it was okay because, I had the bathroom right there. But when I went out shopping or whatever, I would just wear Depends. And then I wore them to work, just in case.
It just got to a point where it was affecting my life, so I went to see a doctor about it.
So when I spoke to my doctor, he referred me to a urologist, which, helped me to understand that I wasn't going crazy, that this is a part of the MS that is affecting me, and I needed to address this before it gets any worse.
Bladder and bowel dysfunction have a really tough impact on people's lives. Research shows us that people's worlds become smaller when they're experiencing bladder and bowel dysfunction. Their social life becomes much more inhibited, and they just lead to a much more isolated state.
When people have bladder issues or some other neurological issues, they feel like you can't treat it, and which is a huge misconception, because I think nowadays we can do a lot for bladder dysfunction.
As soon as people have problems with leakage or chronic urinary tract infection, we're always worried about issues going higher up in the urinary tract. Our big goal is to protect the kidneys.
The purpose of the urinary system is to excrete waste. So we have our kidneys, we have our ureters, which are the tiny tubes that deliver urine from the kidney to the bladder. We have the bladder that should store and empty appropriately.
Normally, when urine comes down from the kidneys and gets into the bladder, it fills up slowly like a balloon. And eventually it reaches a point where the balloon is filled enough that the bladder sends a signal to the brain and says, "Hi, I'm full. Can we go to the bathroom now?" And your brain says, "Not right now, I'm in the middle of a party." Or "Not right now, you're in the middle of a meeting." And when it's time, the brain says, "Okay, now's a great time to go." And so your brain sort of releases the bladder. The bladder contracts. There's a spigot between the bladder and the opening on the outside that has to open and relax, and then the urine gets pushed out as the bladder squeezes.
Then it comes out through the urethra, which is like a straw. The part that closes off the urethra is the sphincter on the bladder, which is made up of the pelvic floor muscle. Now, if this muscle is healthy, it knows when to contract to give effective closure on the urethra so nothing leaks out, and it also knows when to relax to allow the urine to come out. But if the muscle isn't working properly, which we often have for people that have MS, then it may not close properly or it may not open properly. So then we can have problems with both storage of urine, or we can have problems with emptying.
The kidneys don't have any kind of pumping mechanism. They have a kind of gentle inchworming effect as the urine is transmitted from the kidneys down to the bladder. And if the kidneys meet any downstream pressure, they stop filtering, and that urine starts to build up in the kidneys, and it has nowhere to go. And eventually the kidneys start to swell. That's called hydronephrosis. And that ultimately can lead to recurrent infections, stones, and renal failure or kidney failure if not intervened upon.
Bowel and bladder problems in general can come about at any point in the course of multiple sclerosis. And since the spinal cord is a key modulator of both bowel and bladder function, spots or lesions in that area can contribute even early on to changes in mechanics. That being said, oftentimes we see more problems with the bowels and the bladder as the disease course goes on. Progressive MS often presents with worsening symptoms referable to the spinal cord or because of damage to the spinal cord. We often see more bowel and bladder problems in those individuals.
Bladder dysfunction in general in MS is quite common. If you look at the statistics, up to about 80% of people and maybe more actually have bladder dysfunction. And because it's so common, you would think that people would be more willing to talk about it.
The most common presentation of symptoms is going to be urgency, having to get there quick, frequency, going more than 8 times in 24 hours, nocturia, which is getting up more than twice at night, and urge incontinence, which is the inability to get there in time. Some other patients may complain of intermittency, stopping and starting while they're urinating, hesitancy, which is the inability to get it started, or combinations of all of these. And those are the most complicated. But every problem can be fixed.
With the bladder, some of the first signs that they're going to see are leaking a little bit with laughing, coughing, and sneezing, or feeling like they're not fully emptying their bladder. Now, if they do nothing about it, it quickly develops into urgency issues. And then it often develops into urgency urinary incontinence. The first thing they tend
while they're urinating, hesitancy, which is the
because it's so common, you would think that people would be more willing to talk about it.
The most common presentation of symptoms is going to be urgency, having to get there quick, frequency, going more than 8 times in 24 hours, nocturia, which is getting up more than twice at night, and urge incontinence, which is the inability to get there in time. Some other patients may complain of intermittency, stopping and starting while they're urinating, hesitancy, which is the inability to get it started, or combinations of all of these. And those are the most complicated. But every problem can be fixed.
With the bladder, some of the first signs that they're going to see are leaking a little bit with Laughing, coughing, and sneezing, or feeling like they're not fully emptying their bladder. Now, if they do nothing about it, it quickly develops into urgency issues, and then it often develops into urgency urinary incontinence. The first thing they tend to do is decrease their fluid intake. By decreasing their fluid intake, they made the urine so concentrated, it irritated the lining of the bladder, it increased the risk of urinary tract infection, because concentrated urine usually gives mineral deposits and can lead to more and more problems within the bladder. As well, now with dehydration, they increase their constipation. So now their bowel is affected in addition to this.
My issue was just the problem of not being able to hold it. If I felt it, it was too late.
I've always had a passion for motorcycles. When I had the issue where I couldn't hold my bladder, when you went for rides with guys, you know, you were constantly having to stop to use the restroom, and going on a bike ride that might be an hour long, and when you're stopping 4 or 5 times just for me to use the restroom, it's an inconvenience for my friends as well.
I have two really close friends. For our 50th, we spent a week together, and so, you know, I had to bring extra Depends and stuff, and, you know, I just kind of made a joke about them, but it's still embarrassing. Even though we're that close, it's still embarrassing.
It's a very hard thing to talk about. I mean, to my wife, you know, it's not something you can hide. When you were at a point where you were having accidents, you know, it's something that affects her as well. And, you know, you try to hide it as best you can, but the bottom line is that you're going to have a period where someone's going to see it.
I realized that after speaking to my urologist, and after, you know, she gave me the medicine that right now just is a lifesaver, it was easier for me to speak to my mother and my stepfather about it. About, look at, whenever we're driving out of state, I have to stop, you know, I have to go to the bathroom. The more honest I am, it started being easier from me just expressing to my family or my parents, look, we had to stop.
People with MS withdraw from contact with their partner because they're concerned that their bowel or bladder dysfunction makes them no longer attractive. And they're concerned that their bladder may leak during intimacy, or they may have a loss of their bowels during intimacy. It really does create a level of isolation that the average person doesn't understand. I encourage couples to be open with one another and to be honest about what the person with MS needs, what the caregiver feels comfortable providing, and how they can come back together as partners. The The typical symptoms of a urinary tract infection or bladder infection may be increased urgency, increased frequency, burning with urination, and perhaps blood. But often patients with neurologic dysfunction don't have the same symptoms. The infection may cause what's known as a pseudoexacerbation. So it's not a true relapse of the multiple sclerosis, but while you're suffering from this urinary tract infection until it's identified and treated, you may develop changes in your mobility, you may develop changes in your bladder function, increased fatigue, and perhaps even some cognitive dysfunction that a caregiver or partner may recognize. They can start as a simple bladder infection, but rise to the kidneys in a very short period of time, and that's called a pyelonephritis, or a kidney infection. And with that, you develop a very high fever and flu-like symptoms. And this can create a pseudoexacerbation, or even worse, a relapse of the multiple sclerosis.
There are also studies that we're actually currently doing now, sponsored by the National MS Society, to look at whether bladder infections can trigger relapses, and also how often at the time a person presents with a relapse, in fact, they have a urinary tract infection.
If you look statistically, what gets people into the most trouble, it's the secondary complications of MS and urinary tract infections leading to urosepsis.
I think it was at just like my normal, checkup, and I just kind of mentioned that, I was having trouble with my bladder, and that's when he mentioned Dr. Murphy.
I encourage people when they come into my office just to take a deep breath and be as honest as possible. I ask embarrassing questions. I ask if you wet the bed. I ask if you can't get to the bathroom quick enough and you wear diapers. I need that information, and whoever's going to help you needs that information. Once you've had your history, then the provider will do a physical examination to determine if there's other things. So if it's a female, we may have changes that have occurred after a hysterectomy or childbirth, changes in our anatomy that could put us at risk for just bladder droppage or leakage with coughing and sneezing that may be unrelated to the multiple sclerosis. If it's a gentleman, we worry about prostate growth. So some of the symptoms may be just from benign growth of the prostate that a man without MS would have. Then specialized testing needs to occur in order to figure out exactly what the root of the symptoms are coming from. The first test is a urinalysis to look for blood in the urine. And typically, we do what's called urodynamics and a renal ultrasound. So the urodynamic testing involves placing a small catheter in the bladder and filling the bladder with water in real time while part of the catheter is connected to a computer monitor. And while the patient's bladder is being filled, the technician or nurse or advanced practice nurse that's performing the test will be asking questions about sensation. The nurse sits you up and you go ahead and you urinate into a special machine that tells me about pressure and flow. After that test, you go and have an ultrasound. It allows me to look at the kidneys to determine if there's any kidney stones, if there's any swelling of the kidneys. So I want to see that the bladder still looks like a nice little balloon, that it doesn't look stiff and irregular and maybe going to lead to those pressure changes that could affect the kidney function long term. Because storage problems and emptying problems can overlap in their symptomatology, meaning someone who can't hold will have urgency, frequency, and urgent continence, and someone who doesn't empty may have urgency, frequency, and urgent continence. It's very important before trying any medication that someone check to see how much is left in the bladder. And that's what's called post-void residual. That amount that's left behind after you urinate can be measured by either an ultrasound, a formal ultrasound, with a bladder scanner, or by, again, catheterization, where a tube is put into the urethra and the amount that's left behind is measured. Urodynamic testing is the gold standard, and whenever I describe the process of going through urodynamic testing and I say the catheter word, there is absolute silence in the room from the patient. We use a numbing jelly down the urethra. Amount that's left behind after you urinate can be measured by either an ultrasound, a formal ultrasound, with a bladder scanner, or by, again, catheterization, where a tube is put in. Into the urethra and the amount that's left behind is measured. Urodynamic testing is the gold standard, and whenever I describe the process of going through urodynamic testing and I say the catheter word, there is absolute silence in the room from the patient. We use a numbing jelly down the urethra. The catheter is the size of the tip of a ballpoint pen. I get the most important information about the function of your bladder, not just based on your symptoms, but based on what your bladder's doing. And it directs my intervention. It's guiding the treatment individualized for each person. Depending on cognitive function, depending on dexterity, mobility, amount of support at home, I'm able to tailor a treatment program for each person. Treatment may be as simple as some bladder retraining, learning to hold your bladder a little bit longer. It may be fluid management. Instead of drinking 8 cups of coffee a day, you switch to some water.
Physical therapy specific to the pelvic floor, dealing with urinary incontinence or bladder function, is probably the least expensive and one of the effective manners in which to treat urinary bladder issues, urinary incontinence or dysfunctional voiding. The pelvic floor muscle exercises, or otherwise known as Kegels. One of the ways that a patient can tell if they're doing a Kegel the right way, it feels as if the pelvic floor, when they're performing a Kegel, as if the contents of the pelvis are pulling up and in. If you're sitting on a toilet, it's those muscles which get you to be able to start and stop your flow of urine.
There's a couple other really cool techniques that are being done now. There's one called posterior tibial stimulation, where the tibial nerve, which is one of the main nerves that innervates our legs and helps us walk and kicks our foot up when we walk. The urologist and others have figured out that if they stimulate that nerve down by the ankle, that sends a signal back to the sacrum or the sacral plexus, and those bunch of nerves are what innervates the bladder. And by virtue of doing that, that actually can help with the overactivity. There's a sacral interstim implantation that's done now. It's this stimulating device that actually stimulates the same area in the sacrum, which then feeds back to the bladder and helps with the urgency of the incontinence.
Oftentimes medications are used, medications to stop
incontinence, then feeds back to the bladder. Implantation can help with the bladder signal back to when we walk. The urologist and others have figured out that if they stimulate that nerve down by the ankle, that sends a signal back to the sacrum or the sacral plexus, and those bunch of nerves are what innervates the bladder. And by virtue of doing that, that actually can help with the overactivity. There's a sacral interstim implantation that's done now. It's this stimulating device that actually stimulates the same area in the sacrum, which then feeds back to the bladder and helps with the urgency of the incontinence.
Oftentimes medications are used, medications to stop spasms in the bladder, to decrease urgency, frequency, give you a little bit more warning time to get to the bathroom. Sometimes we talk about Botox injections, which is a medication that's used to help relax the bladder and stop some of those spasms. Your bladder should be strong and elastic, very flexible, kind of like a gymnast's muscles. For unknown reasons, patients with neurologic diseases such as MS develop thickening and stiffening of the bladder that prevents elasticity. And what the Botox does when it's injected into those thickened muscle fibers is it tells those muscle fibers to just relax. The Botox, onabotulinum toxin A, again is a brand name, and it is the only one that has been FDA approved for the use inside the bladder. The downside of using Botox is that there is approximately a 6% risk of needing to learn to catheterize, meaning that I might create such a relaxed bladder that you have to help it, maybe once a day, twice a day, by passing a catheter and emptying out the residual. When there is dysfunction with the emptying phase, there really are only two options. One is to perhaps try a medication that's used for prostate problems, but actually works on receptors in a woman's pelvic floor as well. What that medication does is during the time of urination, it helps encourage the pelvic floor to open. It opens that gate just a little wider so the bladder doesn't have to work so hard. If that medication doesn't work and the patient is still retaining urine or is unable to urinate at all, then a catheter is needed to drain that urine out. But as I explain, if you need a cane or a walker for mobility because your legs can't carry you, you need to assist your bladder with this tiny little straw or this catheter because your bladder isn't going to empty on its own. So the use of a catheter to help your bladder empty is an intermittent process. It can be performed anywhere. It can be performed as quickly as the person next to you is using the bathroom. The catheters now are self-contained. They're pre-lubricated. They're very discreet. It can be used anywhere, anytime, just a little hand sanitizer and your catheter. A suprapubic tube is an indwelling catheter that goes through the abdominal wall. It's about a 10-minute surgical procedure. The catheter is placed through the abdominal wall and drains the bladder in the same way as an indwelling catheter, draining to a leg bag. Suprapubic tubes, however, afford patients the ability to be independent, not worry about bathroom access, transferring. They're good in patients who don't have the dexterity to catheterize nor the support system. They're also really important if someone's already developed some skin breakdown. When all else fails, I still have other options available for patients to maximize their quality of life and to protect their kidneys, which is my #1 goal. That might involve some reconstructive surgery, but again, with a lot of education, a lot of time and interaction, that surgery is life-changing for the better.
I tried 3 or 4 different things before I got to the remedy that fixed my problem. And you can have a normal life.
The first attempt that I tried it, it was really, again, it gave me a lot of side effects. I stuck with it. I realized, okay, well, maybe my body is getting acclimated to it. It was just one pill that I take in the morning daily, and it gives me, again, my confidence. I feel that I could be Angel again without being embarrassed.
I've been catheterizing for over a year now, and it's just been, from the time I started it till now, it's just been a smooth process, and it's something that has changed my life tremendously. I mean, I can't imagine what I would be at this point if I didn't do it.
Dr. Murphy put me on a bladder medication, an oral bladder medication, and that was helping. That was great in the beginning. I was still cathing at that time, and we switched to a different bladder medication, all while still cathing. The cathing frequency got more. We just decided that, the operation was not just an option, it was necessary. Now, with everything that has changed with the operation, I can go anywhere. I can pretty much, it's like a person dragging a duffel bag up a mountain. I don't have to do that anymore. That's how it feels.
Yes, I'm limited, but just living my life, because MS is not gonna go away from my body. I'm gonna have this, so I just had to realize how to live my life with MS, not allow MS to live my life for me.
People with MS who come to see me always say, "Why are you asking me about my bowel habits?" And what I explain to them is that the pelvic floor is a figure of 8. So what happens on the front muscle is going to happen with the back muscle, and the two work in concert. They work together. So bad bowel dysfunction can impact their bladder function. And if I don't get both of them corrected, I'm kind of spinning my wheels.
Our bowels are a method to empty waste from our body. So along that trail of taking the waste through the body is in turn pulling the fluids back out of the waste material to reuse it. So up high in the system, the stool is generally pretty soft. As it goes through the system toward the end of the system, the waste gets harder and more formed, and as much fluid as can be released has been released, and then a stool will come out.
Part of what's important in understanding what's a normal bowel routine is understanding, well, what is normal for me? And so it's good to establish that history first and reflect back on one's past to think, is this change that I'm reporting or concern I'm reporting really new, or is that just me? In my experience, bowel dysfunction is often evaluated more by the patient's report. We certainly can see evidence of dysfunction on examinations like abdominal ultrasound or abdominal x-ray, that sort of thing.
People with MS oftentimes restrict their fluid intake in order to manage their bladder dysfunction. And that unfortunately negatively impacts their bowel function by making harder stools and worsening constipation.
So when a person is, let's say they are experiencing constipation, the stool itself moving through the system has been slower. Whatever has happened, it has moved through more slowly, giving the body more time to empty more fluid from the waist, which means that by the time it gets to the colon and the far end of the colon, it has become hard. Those wastes are intended to be let go.
You might be constipated. You might have fecal incontinence, which you interpret as diarrhea, and that's not diarrhea. That's actually your colon is so packed with stool that only the loose stuff can get around, and it seeps out unexpectedly. Can get around. Your colon you interpret as diarrhea, and that's not diarrhea. That's actually your colon is so packed with stool that only the loose stuff. You might be constipated. You might have fecal incontinence, which you interpret as diarrhea, and that's not diarrhea. That's actually your colon is so packed with stool that only the loose stuff can get around, and it seeps out unexpectedly. It can lead to urinary tract infections. If your rectum is full of stool, the bacteria can actually migrate across the rectal wall into your bladder and can put you at risk for urinary tract infections.
With bowel function, we need to have good enough fiber intake. So we want people to have good fruit and vegetable intake, whole grains. They have to have a lot of bulk to their stool so that it passes easier. But one mistake that people sometimes make is that they increase their fiber intake, but they don't balance that with their water intake. And it's really critical that the two are matched.
Exercise, such an important thing for people living with MS, and many people aren't getting enough exercise. And one of the things that does move the bowels more is moving about oneself. And so since exercise we know to be so good for the overall health and so good for treating many of the symptoms that people living with MS already have, that's another early approach that I take to addressing bowel dysfunction.
Some of the interventions that we're going to use for the bladder can worsen constipation. So if the patient comes to me with constipation already as one of the things on their list, I want to know that before I embark on treatment.
A person can learn to regulate their bowels again. The difference is now they have to think about it. as opposed to just it happens. What you'll want to do is to try to give a clue to your body that this is what you're attempting to do. At that time, we want you to go into the restroom and sit on the toilet as if this is what you intend to do. You may not go at all, or you may have an accident. There will be mistakes on the road to learning how to train your body. So you talk about these kinds of lifestyle things that they might be able to do. Have you increased your bulk? Have you increased your fiber? But you have to be careful. You don't ever do them all at once. And you may want to, again, keep a little record, okay? On this particular week, I tried this. On that week, I tried that. So you have some idea of where you started and what you've tried and what success you've had or not. What you do is you try to manage by doing the easiest, most benign, natural things first, and trying to get a person to do a bowel program and all those kinds of things that they can manage on their own. If in time, however, this isn't working or it's worsening, then it might be a time when they would need to see a gastroenterologist.
We all see someone with physical limitations and think it's the wheelchair. We think it's the cane. We think it's the walker. But when you talk to these people, that's not what keeps them at home. It's their bladder. It's their bowel. It's not the loss of their ability to move. It's the loss of a bodily function that we all take for granted.
Before me taking any medicine or being courageous enough to speak to my doctor about my situation I was facing, it was really hard. Knowing that just one single pill will make a difference, I will just make the appointment as soon as possible. If I would have known that only one pill a day will give me back the confidence and the smile and the self-confidence again that I have in just going out and living my life. I love just playing around with the kids because it gives me a sense of joy. I prefer just playing around, playing games, or just, having them beat me up. I just feel that being around those kids, seeing how happy they are to see me, it brings a smile to my face.
I go out on the boat a lot fishing, and it's not like you have a handy restroom, so it limited the time I could spend with my kids. Now I'm living that normal life where I go out on the boat with them a lot. We fish, we spend a lot of time together.
To me, I just feel more independent. I don't need as much help, and it's like breaking a chain. I'm not chained to anything.
No one with MS should be ashamed about bladder or bowel dysfunction. It is not your fault. It is the result of your disease. And I can't stress enough that just the way multiple sclerosis impacts your cognition, your speech, your dexterity, your mobility, it affects your bladder and your bowels, and you can't control that. I want people with MS to feel comfortable talking to whatever provider they feel closest to, whether it's their occupational therapist, their physical therapist, their neurologist, their physiatrist. I want people with MS to understand that things.
Now, there's nothing like getting the waste out and not being constipated. Because when your body digests your food, the leftover that you may call poop or waste needs to get out. And if it's sitting in our colon, it's eventually going to have more bacteria eat at it. It's going to become putrefied, and that eventually can get into our bloodstream and cause a whole bunch of inflammatory changes throughout our body. So my job today is to tell you the many ways that we can become more regular, particularly every day. There's nothing like waking up in the morning, because that's when your body starts to turn on and go to the bathroom. But the key thing for this video is to be regular, to go every day. And there are many millions of people out there that wait several days. And this can be helped by just making a few changes. So try to watch this video to the end, and I know this will help you. Tissues, glands, and cells will not only suffer, but so will our colon. The stool has a tendency to dry up, making it harder to get it out of your system, making you constipated. And when you're constipated, you will get bloated, you will feel heavy, you will feel drained and tired. You will do anything to get this out. But hold on, we're gonna make it happen. So even when you're not thirsty, make sure you're drinking plenty of water throughout the day. It will make a big difference. And one of the greatest things that we can do when it comes to getting rid of that constipation, getting that waste out of our body, is to move. That's right. Walking around, exercising, whatever it is, whatever hobby you enjoy, the more movement we have within the joints, the more we stimulate our nervous system. That nervous system will stimulate the colon. Movement increases peristalsis. Peristalsis is that movement within the colon, so the waste can make its way out. And even after your meals, to keep your glucose levels down, if you get up and walk and just move around, this will make you more insulin sensitive, taking stress off the pancreas, so the glucose can get into the cells much easier, where you can get that energy and you're not going to feel tired, weakened, and fatigued. And you want to make sure you're eating your fiber. You have soluble fiber, which actually makes your cholesterol go down. Great for your cardiovascular system. Your soluble fiber are your fruits and vegetables, your chia seeds, your flax seeds. All that soluble fiber are like prebiotics. It helps feed your microbiome, meaning your system is going to work so much better and you're going to stay so much healthier. And make sure you're getting your probiotics, the good bacteria that you need. Yogurts, kefir, kimchi, sauerkraut, fermented foods, as well as your healthy fats, like your olive oil, your avocados, your nuts, which are great for your cardiovascular system. Your nuts are filled with fiber as well. And a little trick I want to share with you that works great as well is just taking a tablespoon of extra virgin olive oil and just swallowing it just like that. You can chase with a little bit of water. You can do that a few times. Great as well is just taking a tablespoon of extra virgin olive oil and just swallowing it just like that. You can chase with a little bit of water. You can do that a few times a day. I like to look at that oil as like the oil in your car. It keeps everything lubricated. And yes, it's not only healthy for your cardiovascular system and your arteries, but it will definitely help constipation to get your colon moving real quick. And I'm sure that many of you heard of the squatty potty, but don't worry about the name. What we want to do is when we sit on the toilet with our knees higher than our hips, you can take a little stool and put your feet on it. Just leaning forward helps increase the rectal canal angle and allowing the key pelvic muscles to relax within your colon, so bowel movements will become much easier. And hot beverages can do wonderful things for our colon. Waking up first thing in the morning, many people love their coffee. Yes, the caffeine will definitely stimulate it as well. But even like a healthy cup of tea that's nice and hot, that will stimulate peristalsis to get that movement in that colon so you can release your bowels. And just giving yourself a little abdominal massage will stimulate acupressure points as well as the colon to help increase peristalsis and movement. And just doing that for a couple minutes can do wonderful things to help you feel so much better. And Senna, S-E-N-N-A, is an herbal laxative. It comes in teas or capsules. This will help stimulate those nerves in the colon. Yes, it will stimulate it. And as a last resort, you might want to consider this if you're having that significant problem. And our mothers always told us about prunes or prune juice for constipation. Guess what? They were right. Studies have shown that prunes will definitely stimulate the colon and make you go much faster. Now you know the wonderful ways on how you can make your colon happy, which will make you happy. But you must omit those processed refined foods, those foods sitting on the shelf, those sugars, those cereals, those foods
you've been told you have MS, or you've been told your MRI shows you have MS. You may have been told your doctor doesn't know if your MRI shows MS or does it show cerebral vascular disease. So today we're just going to look at a bunch of MRI films of patients with multiple sclerosis. Now I'm going to show you mainly flare sequences, and we're going to start with just a normal flare sequence. And this is a cross section through a person's brain, and flares are sort of gray and ugly, but that's what they look like. And here's another one, just a sort of a gray, ugly, and I want you to imprint this in your brain, and I will show you this off and on in between the abnormal ones. And so here's the third flare sequence, just sort of gray and sort of ugly, a little higher up in the brain. No white matter sequence, just sort of a gray, ugly, but this in your. And so here's the third flare sequence, just sort of gray and sort of ugly, a little higher up in the brain. No white matter, abnormalities at all. And then the first ones we're going to look at are just people that, have sort of very mild MS. Like here's one that just has sort of mild MS, but it just sort of looks like these white matter lesions are just dropped by like an eyedropper. Normally when you see a stroke, it's usually at the end of a blood vessel. They're more outside, and that rim of gray matter on the outside is more white, but all those little white spots are plaques, the plaques of multiple sclerosis. And here's another patient, very similar, just a hodgepodge of little plaques that look like they've almost been dropped on the film. Here's someone with very, very mild MS. This was a lady who had dizziness, nothing else, and really never had any other symptoms, but just a pretty classic MRI for multiple sclerosis, so she had a workup. Here's another lady who came in, and she was having headaches, but she'd never had any MS attacks, and she had these 2 lesions next to the ventricles, fairly classic for multiple sclerosis. And she had an MRI of her cervical spine, and her cervical spine also showed abnormalities that were fairly classic for multiple sclerosis and what we call transverse myelitis. She had this big plaque right here in the middle. And here's another patient who presented with MS, and it just looks like, an eyedropper was just dropping oil on her brain. Really classic. And compare that to one of the old flare ones. I'm going to show you a flare right now, how normal this is. Here's another cut of the same patient, just drops of white matter changes. Here's a patient that had numbness on the left side of her face. It had an episode years ago where she went blind in one eye, like 20 years earlier. Classic MS. Here's a patient, just very large acute lesion in one eye, like 20 years earlier. Classic. And compare that to one of the old flare ones. I'm going to show you a flare right now, how normal this is. Here's another cut of the same patient, just drops of white matter changes. Here's a patient that had numbness on the left side of her face. face. It had an episode years ago where she went blind in one eye, like 20 years earlier. Classic MS. Here's a patient, just very large acute lesion, presented with numbness and paralysis on the right side. Here's another picture of that same patient, just these fulminating MS plaques. And then another image of the same patient. So just compare that once again to the flare sequence, how plain and gray they are. Now, one of the things we talk about with the MRI of multiple sclerosis is that they're periventricular in origin, in location. And I'm going to show you a bunch in a row where the white matter lesions are periventricular. And they also can point at each other. So either side point, what we call Dawson's fingers. It's like you have your four fingers of both hands pointing at each other. Here's another one, patient with pretty severe MS, but look how these parallel fibers or Dawson's fingers point at each other. Then here's a lady who's just dizzy, and man, she had really a lot of MS plaques. Once again, Dawson's fingers pointing at each other, but periventricular. Cerebral vascular disease is often more on the periphery. And then here's a patient who presented with dizziness and ataxia. Really hadn't had any attacks, but had severe MS. And then another patient who presented with double vision, dizziness, and ataxia, difficulty walking, had significant periventricular severe MS. And then another patient who presented with double vision, dizziness, and ataxia, difficulty walking, had significant periventricular white matter lesions. So here that's a lot. Periventricular white matter had significant periventricular white matter lesions. You hear this a lot, periventricular white matter lesions of multiple sclerosis. See, they're dizziness and ataxia, difficulty walking, and significant periventricular. White matter lesions. You hear this a lot, periventricular white matter lesions of multiple sclerosis. See, they're lined up in the middle, pointing at each other, Dawson's fingers. And then you have, as it ages, you can just have severe MS. And here's a patient that probably has cerebral vascular disease and MS. And then sometimes MS can affect the brainstem. Here, this first one, you see a lesion in the pons right in the middle. The second MRI, you see a lesion in the left cerebellar peduncle. This third one, you see a lesion in the right cerebellar peduncle. Now, many times we do an MRI of the brain, and it's, there's some subtle white matter changes. So we always do an MRI of the cervical spine, and we see, and I showed this one earlier, classic transverse myelitis. Here's another one that had significant plaque in her upper cervical cord. She presented with numbness from her nipples down. Here's another lady that presented with numbness, in her shoulders, but not many other symptoms, but had a little plaque in her spinal cord around C5-6. And here's a lady paralyzed from the neck down, severe transverse myelitis. It's huge. You see the blue arrow pointing at the top part of it. Severe spinal cord abnormalities. And another lady with a little plaque in her upper cord. Here's one who's like a 73-year-old man we diagnosed with MS with a plaque in his upper cord. Another 60-year-old patient we diagnosed with MS with multiple plaques. Don't diagnose a lot of older people with MS, but they'll definitely have it. Here's one in the thoracic spine, extensive demyelination of the spinal cord. Here's a lady who had transverse myelitis years ago, and her spinal cord is becoming sort of atrophic and is starting to lose, volume of the spinal cord itself. Extensive transverse myelitis in a patient that presented paraplegic. Extensive transverse myelitis in a patient paralyzed from the neck down. He eventually died from respiratory depression because it moved up into the brainstem. Another person with a small plaque around C3-4. Another thing we do is these sagittal flares, and a lot of times they don't order these, but you see in the corpus callosum, in the genuine splitting of the corpus callosum, you see these white matter lesions. Sometimes, if you see that, they have MS or some kind of primary demyelinating disease. Here's another one. Throughout the corpus callosum. Corpus callosum connects the two sides of the brain together. And here's another one with a little white matter lesion in the corpus callosum. Here's a fourth one. A lot of white matter changes in the corpus callosum, not much elsewhere. Classic for MS. And another one with 2 lesions in the corpus callosum. A lot of times this really helps, particularly people that have a lot of cerebral vascular disease. So we go back to the beginning and look at this flare sequence, just how plain it looks. Just gray and plain and ugly. And then you look at one of these MS patients, huge difference. So that's the MRI of MS. Very difficult to make this interpretation differentiating between MS and cerebral vascular disease, but I'm going to show you some films, another video of patients that had mini strokes. Probably for every 100 patients that are sent to me, when MS is mentioned on a radiology report, one of them have MS, the rest of them have cerebral vascular disease.
Cognitive changes in MS, for better or for worse, tend to be very insidious, very slow moving. And what that means is, well, on the one hand, it's good news. It's not an overnight thing, right? You don't wake up one morning and you have a different brain than you went to sleep with. But the problem with the insidiousness of it is that it leaves the person who's experiencing it feeling very unsure. Like, is this real? Am I imagining this? And if you feel that something is off, you don't have to really think further than that. You can act on that, and you can talk to your doctor. You can reach out and find resources to explore that, as scary as that can be. Listen to yourself and listen to others. And that's another question that I ask people when they end up in my office, which is, has anybody around you mentioned any changes? Because sometimes others see things in us that we don't see for ourselves, and that can be helpful as you come in for an evaluation. This isn't like you're going to pass or fail. This is, let's get to the bottom of what your strengths and weaknesses are so that we can help you play to your strengths and downplay your weaknesses, fatigue, depression, anxiety, but also these modifiable lifestyle factors that we're going to dig into. I want to know about your exercise habits. I want to know about your sleep. I want to know about your diet, and I want to know about your social support. So those are all the questions that I'm going to be asking you about when we sit down and talk. And after we've had that time together, I'm going to administer some paper and pencil tests, which brings more people to the sort of anxiety-provoking aspect of the evaluation. So I'm going to bring all of that information together, and I'm going to try to formulate a profile of you that helps us both understand what there is here that we can actually act upon. One thing that I'm a big proponent of is tracking our own patterns. And this can be very, very simple. Get a little notebook, keep it next to your bed maybe, and make notes in it, maybe in the morning and at night. And notes can be about how well rested you feel when you wake up. How many hours did you sleep? How many times did you go up and go to the bathroom? How's your mood today? And the better you understand yourself, the better you can anticipate things. You can adjust your expectations. You might realize, oh gosh, every day around 2 o'clock, I start to feel kind of depressed, but I also feel really fatigued. Maybe there's a connection. Be proactive. This is not the time to ignore a signal that your body gives you, that your brain gives you. If something's worrying you, let's check it out. Let's do it together. You don't have to be alone with it. Take it to your doctor, mention it, bring it up. Keep it next to your bed, maybe, and make notes in it, maybe in the morning and at night. And notes can be about how well rested you feel when you wake up. How many hours did you sleep? How many times did you go up and go to the bathroom? How's your mood today? And the better you understand yourself, the better you can anticipate things. You can adjust your expectations. You might realize, oh gosh, every day around 2 o'clock, I start to feel kind of depressed, but I also feel really fatigued. Maybe there's a connection. Be proactive. This is not the time to ignore a signal that your body gives you, that your brain gives you. If something's worrying you, let's check it out. Let's do it together. You don't have to be alone with it. Take it to your doctor, mention it, bring it up.
Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee, and currently I serve on the MS Society's Community Review of MS Research Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect, and to connect you with experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS Navigators are online throughout today's program, answering questions and connecting you to resources. More than half of the people living with MS experience cognitive changes. And these kinds of changes can have a significant impact on your activities, relationships, employment, and your overall quality of life. Dr. Nancy Charavalati is joining us today to talk about how cognitive rehabilitation can be effective in developing ways to compensate for those changes. Dr. Charavalati is the director for the Center of Neuropsychology and Neuroscience Research and the Center for Traumatic Brain Injury Research at Kessler Foundation. She's also a research professor of physical medicine and rehabilitation at Rutgers, New Jersey Medical School. And Dr. Charavalati's research is focused on cognitive rehabilitation, particularly in new learning, memory, and processing speed. Welcome, Dr. Charavalati. Thanks for being with us today.
Of course, thanks for having me.
I hope you'll start us off by explaining which cognitive functions are commonly affected by MS and what are the first signs of cognitive impairment?
Of course. Well, processing speed is by far the most common cognitive deficit seen in persons with MS, and that's a generalized slowing of the ability to process information. After that follows new learning and memory. That's also fairly common in multiple sclerosis. Some patients will also experience difficulty with executive functions or attention, but those are a little bit less common than processing speed and new learning and memory. In regard to early signs, many patients will report feeling cloudy or having trouble following along in conversations. It's particularly noticeable early on when there are multiple people involved in the conversation or there are a lot of distractors, as in a cocktail party situation. Or sometimes people will report difficulty following along when they're watching movies because the information is going really, really quickly. So that's what patients generally experience in the beginning.
We've heard from Rhonda, and Rhonda tells us she's heard that cognitive changes only affect people living with progressive MS. Rhonda wants to know whether that's true.
That is not true. Across subtypes of multiple sclerosis, up to 70% of people with MS will have cognitive deficits. That percentage is lower with relapsing remitting MS, so it may be closer to 50% of the relapsing remitting population, and it's a little bit higher in progressive MS, more closer to 80%. But cognitive deficits do present across all MS subtypes.
Brian got in touch, said he wants to know what's actually happening in the brain when cognitive dysfunction begins. He's wondering whether it's related to lesions on the brain.
So, disability progression and cognitive functions tend to show a stronger link with neurodegeneration or brain volume loss. So, the research on this continues, as well as looking at its connection to cognition. So, more research is certainly needed in regard to specific cognitive functions and patterns of volume loss in different brain regions.
The National MS Society brought together a group of experts to develop guidelines to improve cognitive screenings and the management of these cognitive symptoms. How do these guidelines help people with MS?
So these guidelines are very, very important because they raise awareness of the importance of cognitive deficits in MS. And they emphasize that importance for all professionals because professionals really do read those guidelines. So cognitive deficits have a tremendous impact on everyday life, but very often they'll go unnoticed or they won't be documented. And what these guidelines do is they really help the physicians pay attention to cognitive deficits and refer for the appropriate evaluation and services.
What should someone expect when they go for a cognitive screening?
So that varies quite a bit with the clinician, but when someone is going for a cognitive screening, if they're going for a screening appointment, I would expect a shorter appointment in which patients are administered a small number of tests, and it would be likely 3 or 4 tests that assess processing speed as well as new learning and memory. If they're going for a fuller neuropsychological battery, that could take 3 or 4 hours, and that will be more of a broader evaluation of many different aspects of daily functioning. One thing they should definitely expect is to complete the symbol digit modalities test. That is a test of processing speed that has been shown to be very sensitive to the processing speed deficits that people with MS experience. So they will most definitely complete the SDMT along with other measures.
Cognitive rehabilitation may be a new subject for some of our viewers. So can you tell us what cognitive rehab is and how it can be helpful for someone experiencing cognitive changes?
So cognitive rehabilitation is a set of interventions. It's not only one intervention. So there are a number of different ways to do cognitive rehabilitation. And this set of intervention aims to improve a person's ability to perform cognitive tasks by either retraining previously learned tasks or by teaching.
And how it can be helpful for someone experiencing cognitive changes.
So cognitive rehabilitation is a set of interventions. It's not only one intervention. So there are a number of different ways to do cognitive rehabilitation. And this set of intervention aims to improve a person's ability to perform cognitive tasks by either retraining previously learned tasks or by teaching compensatory strategies. The cognitive rehabilitation does not involve medications. It's usually done with a therapist, and it's done either one-on-one or in a group setting.
Cognitive rehabilitation includes restorative activities and compensatory activities. Can you help us understand the difference between the two and maybe share some examples?
Sure. Restorative cognitive rehabilitation refers to methods that are looking to improve cognitive function by reinstating or strengthening the functions a person has either lost or is struggling with. So restorative cognitive rehabilitation helps a person practice skills so they can improve. And it is based on the theory of neuroplasticity, which suggests that the brain will change with practice. In contrast, compensatory cognitive rehabilitation helps a person sort of work around their injury or develop new ways to do something. So compensatory cognitive rehabilitation can involve, there are two different types. It can involve internal or external strategies. So we all use, these are classic examples. We all use external strategies. We all have iPhones. And on those iPhones, at least on my phone, everything is in there. I have my calendar, I have my phone number, I have my to-do list. That's an external rehabilitation strategy. But there are also internal ones. And much of cognitive rehabilitation utilizes internal compensatory strategies in order to help a person be able to learn and remember new information. So an example of an internal strategy might be using imagery to remember a word, or using imagery to remember a person's name. My husband, again, this is another thing that everybody does in daily life. My husband uses a strategy in which he knows baseball players' numbers because he is a huge baseball fan. So when he has to remember numbers, he doesn't remember the numbers at all. He remembers the players' names. So as an example, if he has to remember 1323, you'll hear him say Alex Rodriguez, Don Mattingly. He's a Yankees fan. So people do it in everyday life. This is nothing new, but what we like to do is teach persons with MS to use these strategies because they really help a lot.
Well, while we're talking about some of these strategies, I want to point out that you and your colleagues have made incredible advancements in the field of cognitive rehabilitation. The modified story memory technique was researched and developed at Kessler Foundation, and today it's considered Class 1 evidence, meaning that it's been tested and proven to be highly effective at improving memory. Tell us about this therapy and how it can help people with MS.
So the modified story memory technique is a 10-session cognitive rehabilitation program. It really teaches compensatory internal strategies to help someone learn and remember new information. Through these 10 sessions, the person is taught to use two strategies to enhance learning and memory. In sessions 1 through 4, we teach imagery. So we present a story and we ask people to form mental images of that story. And as we move through those sessions, we give them tips on how to improve their imagery. Then we move on to the second strategy in sessions 5 through 8, which is context. So in sessions 5 through 8, we're teaching people to put unrelated information together in a meaningful context. Then we tell them to use what they learned in sessions 1 through 4 with imagery and combine the context with the imagery. Finally, in sessions 9 and 10, we teach them how to use these skills in their everyday life. And that's really important, that generalization. So we've done a lot of research on the story memory technique, and we continue to do so. And we found that not only does the treatment improve learning and memory, but patients also report an improvement in their everyday lives.
A research team studied the modified story memory technique in Spanish-speaking individuals, and they found similar improvements in memory. Why was this outcome so significant?
So we live in a very diverse country, especially where I live in the New York area, but so many other areas as well. So especially where I live in the New York area, but so many other areas as well. So the patients that we serve are not always English speaking patients. Many patients present with Spanish as their primary language. However, we have very, very few evidence-based treatments to be able to administer to someone whose primary language is Spanish. So this is really huge because this is a large population and we really need to be able to serve these folks. And what all this data means is that the story memory technique is valid using when administered in the Spanish language to a Spanish speaking individual.
Some of our viewers may be wondering if modified story memory technique is available to them. So how can someone determine whether their healthcare professional has been trained to administer this specific therapy?
So the best thing to do would be to ask your healthcare professional if they've heard of it and if they're trained to do it. If they're not, the healthcare professional can gain access to it by reaching out to us. The training is actually very straightforward. It's not very difficult to administer. It's highly manualized, and we're always here and available to answer questions.
You know, as you mentioned at the start of our conversation, processing speed is one of the most common cognitive impairments that affect people with MS. You led a clinical trial that studied ways to improve processing speed. What did you learn?
So the treatment program that we used in processing speed was one that had been validated in healthy aging. So it was shown to improve processing speed in healthy aging. We showed that people with MS benefit on a task that's similar to the training task. So they do show improvement in their processing speed ability. What we did not show, though, was that the improvement generalized to daily life. So the improvement that we saw post-treatment was not evident in someone's daily life. Now, this, going back to what we were discussing earlier, is a restorative program, and it focused on the skill and practice of the skill within different difficulty levels. So what these results told us was that while the treatment worked, we need to incorporate more into the treatment to promote this generalization to daily life, because that's what people care about, is how they're able to function in daily life.
Recently published results from a large international clinical trial showed that cognitive rehabilitation and exercise can improve processing speed in people with progressive MS. We know that exercise is important for our physical health. How important is exercise or physical activity for our cognitive function?
Extremely important. I cannot overemphasize the importance of being active. And this is true for everyone, not only individuals who have multiple sclerosis. Exercise is very important to maintaining optimal cognition. And we're actually doing research now that looks at the benefit of combining the story memory technique with exercise in order to maximize cognitive ability. And this research is actually funded by the National MS Society.
Lorena tells us she was diagnosed with MS last year, and lately she's been having problems remembering routine tasks at home. She also gets lost sometimes when she takes walks in her neighborhood, and she's concerned she may be experiencing the first signs of cognitive decline. What advice do you have for Lorena?
Get a neuropsychological evaluation. That is really the first thing you have to do. And you could do this by going to your neurologist, telling him or her the problems that you're having, and asking for a referral for a neuropsychological evaluation. Most neurologists know several neuropsychologists, and MS centers in particular have neurologists that are actually part of their center. That evaluation will help you and your doctor in determining what types of problems you're having. And then once you know that, you'll be able to figure out what you can potentially do to help alleviate some of those cognitive problems.
Scott says that he has MS, but he hasn't experienced any cognitive changes.
Psychologists and MS centers in particular have neurologists that are actually part of their center. That evaluation will help you and your doctor in determining what types of problems you're having. And then once you know that, you'll be able to figure out what you can potentially do to help alleviate some of those cognitive problems.
Scott says that he has MS, but he hasn't experienced any cognitive changes. He wants to know if there are proactive steps he can take to prevent cognitive impairment in the future.
So this is a very common question, and not only for people who have MS, healthy people in their 50s and 60s that don't want to develop dementia later in life ask this question all the time. And the answer is lifestyle. Lifestyle is so important. So first, as we mentioned earlier, exercise. Make sure you exercise, and brisk walking is enough. You don't have to be a marathoner. Brisk walking is good. Eat a healthy diet, and in particular, stay cognitively active. So by cognitively active, I mean challenge yourself intellectually. So for some people, this may mean reading the Wall Street Journal or the New York Times. That's not me. For other people, this may mean learning a new skill, like maybe learning a new instrument or learning a new language, something that you're interested in. So it all depends on your interests, but it's really important to challenge your mind and continue to learn no matter how old you are. Another important factor in staving off cognitive decline is social functioning, maintaining family or friends, having a social support network. That's really, really important. And if you don't have that, join a support group. Try to get out and try to interact with people because that's really important in preventing.